admitted as complete or incomplete. The more there is an incidence of the injury to the neurological level associated with spine injury is common in cervical area. The other important point is, does the percentage of canal encroachment determine the neurological deficit? Here I want to go little bit further. This is when we are seeing the spinal canal, there is a fracture and there is a retropulsion of the fragments. Whereas in this particular example, there is a retropulsion, canal narrowing is only 35%. Whereas here in this example, in this CT picture, the encroachment of the canal is almost all 70%. Definitely this will influence on the neurological damage. At the same time, natural history of fracture healing. This is, we know any fracture will heal in the adults within 3 months. 90% of fractures heal with adequate but not necessary perfect reduction. Particularly in the spine, they heal. It need not be a perfect reduction. See that this is the classical example. The retropulsar fragment is there. You see the retropulsar fragment immediately after injury, and patient had partial neurological deficit. And the same one after 6 months, the same patient CT shows the retropulsar fragment get absorbed and the canal diameter is maintained and the patient neurologically recovered. At the same time, is it mandatory to internally fix the spine for better healing? The controversy that there are two schools. One school always tells, if there is a fractured spine, go and fix, give the stability and mobilize early. There is other school, don't be hurry. If it is not causing the damage to the neurological status, you need not fix. So, is it mandatory or not mandatory? It is also dictated by the neurological involvement, level of involvement. The other example, you can see the line drawn. The classical, the retropulsion of the fragment, the body, vertebral body moved back, whereas it is nicely remodeled in a span of 6 months, the remodeled the L1 vertebra. So there is no surgical intervention, and with the rest, with non-operative management, this patient recovered well. Look at the management strategies. When we are planning for the overall concepts of management, we know with the lot of majority of these patients are polytraumatized patients. So we have to search for the other injuries, particularly in spinal injuries. And immediate splinting is the essential part in the initial management. One has to focus on the vital signs. ABC will talk. Those things we have to follow. And a detailed neurological evaluation is very important, and this documentation will help us to assess the prognosis and to tell us how the patient is recovering in coming days. And a detailed radiographic evaluation to see the bony architecture. No doubt we have to go for a CT scan and to see the cord status and other soft tissue problems. The MRI plays the major role. Coming to the management, no doubt there are non-operative and operative managements. So when we look at the non-operative management, can spinal injuries be treated non-operatively? Yes or no? Yes, no doubt. They can be treated non-operatively. Does it make any difference in neurological recovery? This is another question, a controversial question. If we won't operate, already patient have some neurological deficit. If we operate, can he recover from that? If we won't operate, does he won't recover? No. If there is a compression on the cord and really requires the decompression, yes, with the decompression he can recover. But there is a permanent transection of the cord, or there is a permanent transection of the roots. definitely if you operate or if we won't operate, there won't be any neurological recovery. The other one, controversy is, can the spine be immobilized without surgical stabilization? Yes. The spine can be immobilized. There are a lot of gadgets in the market. The spinal jockets and halo braces. I'll show some of the examples. Definitely, the spine can be immobilized without surgical intervention. And this short word, another controversy topic is the giving the methylprednisolone at the acute stage. No doubt, there are a lot of protocols are there for this bolus dose of methylprednisolone. It should be given within 8 hours. The main benefit is it reduces the hemorrhage, and also it reduces the edema of the heart, and also it reduces the damage, further damage to the spinal cord. But said so, the adverse effects are gastrointestinal disturbances, muscular problems, and other one, avascular necrosis. And a lot of problems are there with this bolus dosage of prednisolone. No doubt, these are the picture I captured, the non-operative management. You can see that they're tied to the one side head to the stick, other side the pelvis is tied, and the traction is applied to reduce the spine non-operatively and maintain that posture for the recovery. This started way back. Here we can see a fractured cervical spine C3 get fractured, and this, if we plan, there is no neurological deficit. So such cases, definitely we can give halo vest traction and patient can be mobilized. This halo vest will give complete immobilization of the cervical spine. This example which I done way back in 2001 for this patient. And what is the role of stem cells? Still, they are at experimental age across the world. Till now, there is no proof that a specific research or specific module will help the patients who had complete spinal cord injuries. But said so, the cat and mouse models show some recovery promoted, but some functional improvement, but the results are not yet proven when the patient had complete spinal cord injury. Coming to the surgical intervention, when we have to intervene these fractures, when there is a compression fractures of the spine involving more than 2 columns, which we discussed in the classification, the same thing, the burst fractures and the flexion distraction injuries and fracture dislocations, and we'll see all the examples in coming up my talk. And when we want to restore the alignment, entire alignment of the spine in the coronal, sagittal or plane alignment is very important. What is the goal when we are planning for a surgical treatment? The goal must be to stabilize, to decompress, to protect, and to restore and improve. What stabilization? We have to stabilize the bony column. The spine is unstable. We have to stabilize, put back in position, and use the implants to stabilize those unstable spines. Decompression, yes. We saw some of the examples in the CT scan where there is a retropulsion of the fragments which come and compress the spinal cord and roots. When we are intervening surgically, we go in and we remove the compressing fragments. So when decompressing the neurological spinal cord, there is much better chance of recovery in the partial injuries of the spinal cord. Then the next goal must be protect the spinal cord injured when it is not complete. So we can protect the spinal cord by decompressing and all. Finally, we have to restore and improve the entire sagittal and coronal alignment of the entire spine. So, set the goals. What are the objectives of spinal stabilization? One, we have to main objective is to get a sound bony fusion of unstable spine to provide good stability. That is the main objective, bony union, the fractured spine. The second one is internal fixation has the ability to provide excellent short-term stability and enhance the success rate of surgical fusion, especially when the spine is fractured at multiple levels. This is the one can post here when we are talking about the surgical instrumentation, surgical stabilization of the spine. We can stabilize the spine from front, that is anterior, or we can stabilize the spine from back. There is controversies once again in the which approach we have to stabilize the spine. Whether it has to be stabilized from the front. If the thoracic spine is involved, we have to do thoracotomy and go front and fix the spine. Or lumbar spine from front. We have extra peritoneal approach. We have to go front and stabilize or do it posterior. So look at that. This is can posterior instrumentation produce indirect decompression. See here, the CT scan, preoperative, the retropulsion is there, and the close reduction was done, and you can see the two rods which are stabilized, and the retropulsed fragment went back, and automatic decompression can occur in those situations. This posterior instrumentation is, just now we talked about that, is as good as anterior. Yes, anterior decompression increases axoplasmal flow and decrease ischemia, because once we go approach the spine anteriorly, directly we can reach the spinal cord anteriorly, and we can reach the retropulsed bony fragment. We can get it away from there, and hence the axoplasmal flow will be improved, and there is a chance of decrease in the ischemia. We know at the level of D8 to D10, the spinal cord is spinal canal is very narrow. In such situations, anterior decompression will reduce the ischemia. At the same time, no difference in neurological recovery, maintenance of reduction or implant failures. There is another study, but he says that the controversy, once again, there is no difference in neurology. That we know, once there is a permanent neurological damage, definitely it is not possible. This is one of the, when I look at this file, this X-ray, my memory goes back to 2001. One of my friends, when I was in UK, in the middle of the night, he dived into the shallow swimming pool at 11 o'clock in the night. So it very clearly shows he had the fracture dislocation. The facets, both the facets jumped out. So emergently we took up, anteriorly we went, opened and grafted and fixed it. And after 3 months, he came with quadriplegia and he recovered and went back. So that is the things one can achieve. The other example, can see the spine. This is thoracolumbar junction. How it's a flexion rotation injury. You can see the entire spine went to kyphosis, and you see the alignment, sagittal alignment, they are in different planes and entire dislocation happened, particularly in this case. And he had a chest injury, fractures rib and pneumothorax. So he was treated for that first, and then you can see the CT scan, how clearly shows the fracture dislocation of the spine from the all three-dimensionally we can see and assess. No doubt, in this case, apart from the spine fracture and dislocation, there is a complete transection of the cord. That is the most thing where this is a permanent damage to the spine. And this taken for the surgery. I done the oldest that time, the spinal instrumentation with sublaminar wires and hard shell rectangle. So only one, this particular case operated mainly for give the stability to the spine for rehabilitation, not for the recovery of the from the neurological status. That is the post-op X-ray. I hope you remember the pre-op CT and all. The alignment of the spine is maintained post-operative. This is another fracture, dislocation at the D910. And